It can feel so often that what we do doesn't make a difference. The true saves are so far and few between. A lot of the critically ill patients we transport feel like they never had a chance, no matter what we did. The literature focuses so much on survival with good neurological outcomes, or survival to discharge, as the outcomes of interest for whether or not our treatments were a success. But there's a missing data point that does not get included in these studies, and that is survival with successful organ donation. Does the care we provide have an impact on whether or not a patient may be eligible for organ donation? Now, there are huge ethical quandaries when you begin asking this question, and we'll discuss those a little in today's episode. But these quote-unquote lost cause cases, the cases that never had a chance at survival despite your heroic efforts, may still have some good that comes from the tragedy. But what is EMS's role in these cases? Honestly, we don't know. There's an ongoing study right now looking at how often is EMS involved at some point in these organ donation cases. Based on the preliminary numbers, you may have a bigger impact than you realized. Any role we may or may not decide to play in the pre-hospital setting is going to require a lot more research and, even more importantly, thoughtful, ethical discussions to assure it is done right. Our first priority should always be to treat the patient in front of us with evidence-based practice to optimize their outcomes. We probably shouldn't let the thought of organ donation affect our decisions at this time in the pre-hospital setting. Still, I think we need to start having the ethical discussions and doing the research to better elicit what our role is. Today's guest is Chris Meeks, who is a critical care flight paramedic and organ recovery coordinator for LifeShare in Oklahoma. The goal for today's episode is not to change your practice at all, but to introduce us to the concept of organ donation and to help you realize that even if you may see a lot of poor outcomes, the world is not black and white, and you may actually have more positive impact than you realize, even in these tragic cases.
Here you on 8. You on 8. Okay, you're clear. Stand by for your base.
Chris, we're on site at the Fast 24 conference that FlightBridge put on. I unfortunately missed your talk, which sounds like just a really fascinating talk. So I'm going to essentially learn about it with the listeners right now. We chatted a little bit right before I started recording, but set us off. Kind of what was the topic you covered today?
So I talked about brain death being a missing data point for EMS. And the reality is that we transport a lot of traumatic brain injuries and cardiac arrest patients. We get a lot of ROSC in the field. And we look for those one-offs, the miracles where people are leaving with true neurofunction that gives quality of life. And we don't really track the patients that make it to the hospital but don't quite leave. They're a data set, but we're not paying attention to what happens after we drop them at the hospital. And what I came to realize when I started working in organ donation was that EMS has a significant impact on organ donation and these patients. So the question that I posed was, what is the role of EMS for organ donation and what is the impact? And what I found and what I presented in the talk is that it's a pretty broad number because I'm waiting for the study to finalize. So I'm going to say approximately 80% of organ donors were managed in the pre-hospital setting at some point in their clinical course. And when we jumped back and looked at the history of organ donation, we know that it became a commonality between 1950 and 1965. The specific dates are kind of arbitrary. EMS modernized and became aggressive in pre-hospital care in that same timeline. And all of a sudden, patients are arriving at the facility with meaningful potential. And the fact of the matter is that not every patient that has meaningful potential gets to go home. And we tend to look at that as a loss and a failure. But at the end of the day, we were able to impact a patient in a way that now's disposition has the ability to impact upwards of 80 people through organ and tissue donation. And our impact on society and the people that we are committed to serve has just magnified by potentially 80 to 84 times.
Yeah. So I guess, what is our role as an EMS provider in that situation?
That's a really good question and not a straightforward one to answer. And I'll be very clear that I'm trying to answer these questions myself right now. And it's important that we remember that organ donation is a very new field of medicine. It's newer than EMS when we really get down into the nitty-gritty of it. And we're just now starting to pose these questions because we're really starting to recognize our impact. When EMS does well, organ donation does well. And those patients do really well. When we put it into the context of you have a 19-year-old brain dead patient who's, it's just an awful tragedy. We can have hope in that tragedy because maybe a 6-year-old gets a heart that's going to last them for another 50 years. And there's life and love in that tragedy. We can't change the fact that that happened.
Yeah.
But we can provide hope and a hopeless outcome. And that is a really important thing. So seeing the direct impact that EMS, that we know we're having on donation. Now the question that we ask, is there a way that we can be doing it better? Or maybe does EMS need to put up a barrier and say, we're very glad for this impact, but ethically we need to step to the side? Those are the questions we're trying to answer right now, is where do we go from here?
Yeah, elicit that a little more. What is the ethical concern there?
Well, I never want anybody to feel that I didn't care for their loved one as well as I could have because I wanted to procure their organs. Organ procurement is a chosen disposition. It's something that should be decided by the donor, the patient, or their family on behalf of that patient. It's not something that we should be considering inside of primary resuscitative medicine. And my fear is that if EMS is over-involved, that we could potentially run into the scenario that we've all feared, which is maybe I'm not going to do X, Y, and Z because this patient's a donor and I think that they don't have any chance. Well, we know they may have a chance. So personally, I feel that EMS's role is to continue to research our impact and look for opportunities to positively impact organ donation. But I am very hesitant to say that we're going to find an ethical way to look at the driver's license and see that they have that red heart. There's space for us to do tissue referrals for pre-hospital pronouncements whenever somebody does not achieve ROSC in the field and can still donate tissue if they wanted to. There's space for early referral to the hospital. And I think that's a really important role for EMS. And it's not about saying, hey, you should start this organ donation case. It's about letting them know that a patient that you see has a high probability of having a poor prognosis has entered this facility. And the sooner we can follow that case, if it does become a case where organ donation is a potential and it is legal and ethical to discuss that with the family, the sooner that we've started reviewing that case, the better that timing can be, and it's better for the family. And I won't say that it directly impacts the organ donation itself, but if I can sit down with a loved one and allow them the opportunity to have 1 or 2 days to process this as an option while they wait to see how their loved one's doing, then that's going to be a lot easier on their heart than if I show up at the last minute and say, hey, this is on the table. Would you like to slow this whole process down and kind of carry your loved one a few extra days? That's a much harder conversation to have.
Yeah, sure. Who qualifies for organ donation? Like, what are the criteria?
So I can only speak for LifeShare of Oklahoma. My personal organization is paramedics, nurses, and respiratory therapists.
Okay. And what do you guys do?
So my job as an ORC, I'm an organ recovery coordinator, is once a family or a patient has elected donation as their disposition, we'll go to the bedside and conduct an initial evaluation, consult our physicians who are specialists in transplant, and determine what is viable. And at this point, the family's already decided that this is what they want. We've made sure that all the ethical lines are where they belong, and we'll then start either supporting the physicians on site and consulting, helping them manage the patient that optimizes organ performance. Or in the cases of brain death, we'll actually assume care of that patient, and I'll be bedside, and we have a very extensive standing order set. So we're doing everything from managing hyperkalemia, managing diabetes insipidus, and any of the other 9,000 things that can go wrong when your brain stops working. That kind of becomes our specialty of medicine, and we manage that. Once the patient's managed, we get to run the match list and find homes for those gifts, and then we'll coordinate the teams into the OR, set the OR, and then we're physically present for the donation.
I think when we think about organ donation, we often think about the big things like liver, kidney, heart, but there are a lot more things that can be donated. What are some of the other less commonly thought of
Absolutely. Pancreas is a newer one that's very impactful, especially in the world of pediatrics and diabetes research. You can even donate islet cells of your pancreas, even if your pancreas doesn't qualify to allow research to take place. Intestine is a new one. It's very difficult to qualify to donate your intestine, but for the recipients who do get it, it's very life-changing. It provides a new access to quality of life they wouldn't have had. One of the ones I really love to talk about is on the tissue side is the eyes. The eyes are a difficult thing for us to discuss in the world of donation because it's such a sensitive topic for humans in general. But I know that if I were to die and my eyes provided somebody the opportunity to see the world in a way they hadn't been able to and to live and interact with their world, I'm very okay with that premonition. And the spinal cord. The spinal cord's a really cool one, using that as a graft to help people work on rehab and getting to mobility and sensation back faster. There's a lot of benefit there. That those 75 plus pieces of tissue, they all carry some attachment to quality of life. Otherwise, the risk the risk would supersede the benefit.
Yeah. I know it's got to be incredibly nuanced, like patient to patient and clinical scenario and factors, but are there any broad strokes of what either qualifies or disqualifies a patient for organ donation?
Absolutely. So the word serologies is what pops into my head almost immediately. We'll run a very extensive serology study at the start of a case and look for infectious disease that could negatively impact the patient. So serology is a pretty fast way to either increase the risk, which makes it hard to match, or to knock the patient out. And then, of course, like long-standing conditions, like if you have congestive heart failure, we're not going to be able to pursue your heart. But what we may be able to do is pursue the valves of your heart. So somebody who's waiting on a heart has some more time. Or we can look at, alcoholic liver cirrhosis. Alcoholic liver cirrhosis can disqualify a liver. But as technology has gotten better, we were able to use organs a little bit more efficiently. So for instance, if you die of an overdose, we can still use your kidneys and your liver. But if you die of a polynephritis and sepsis, then we're not even going to pursue your kidneys. Very recently, we had a patient who had some myocardial dysfunction early on in the case, and we'd elected that his heart was not a candidate just because it was too risky for the recipients. By the time we made it to the OR, his heart had actually very well recovered. We repeated our echo, and he'd gone from an EF of 14% to 74%, which is flabbergasting improvement. But at the end of the day, we ended up able to place his heart, and it may not be the highest quality match, but that patient's going to get at least a decade of life back out of that. Yeah. And so there's a lot of things that can knock an organ out, but at the end of the day, it all comes down to the individual on the list and that risk-benefit analysis.
Yeah. What about age?
Age is a great question. Pretty much 0 to 65, and depending on your OPO and if I'm saying these things correctly or not, there's going to be some differences. And then the type of donor you are is going to matter there as well. If you're donating tissue, the cutoff is up into the 90s, but if you're going to be a DCD, a donation after circulatory demise, that age is going to drop down into the 60s, just because the organs aren't going to tolerate the stress of the death and withdrawal process as well.
Yeah, well, such an important part of medicine, and something that we think about, but I don't know that we realize it as much. And I think it was so important. You started this off talking about how sometimes it can feel like you're not doing a lot of good, especially when, you treat a lot of patients who don't have great chances of survival. But even if that patient doesn't survive, the amazing aggressive care that you gave pre-hospitally may have set that patient up to affect
absolutely
tens of other patients, which is a huge difference. And so what you do matters, and you're making a difference.
For all clinicians across the board, if you're getting a patient to a hospital and giving that family an extra day with them, we have to see the quality in that. And then when we magnify that by the number of potential benefits of organ donation and the realization that we can't change that tragedy that happened, but we can help find a way to make it a little bit better, that's a really powerful thing. And for me as a paramedic, it makes me reflect on like the last 10 to 15 years of my life and see I may only be able to count on one hand the number of cardiac arrest survivors that I've gotten to see leave the hospital. I may only be able to count on one hand the number of traumatic brain injury survivors that have a good, meaningful quality of life. But in this position, I can support the human beings that are experiencing this loss, and I can support a miracle of life coming out of this tragedy. And that gives people hope. And I think at the core of EMS, our existence is hope. People know that there's somebody to call, somebody to come help them. And even when their mother, their son, their daughter is going to be lost, there's somebody there that can help them find that hope so they can just drive on, move on, and be okay.
Thank you so much for coming to talk about this, Chris, and thank you for what you do.
Thank you. I love being here.
Thanks for tuning in to this incredibly important yet rarely talked about topic. Again, I want to emphasize at this point in time, this is probably not a concept we need to think about on shift, but it is something we need to start thinking about off of shift. We need to start having these ethical discussions about what EMS's role is in organ donation outcomes. We need to consider adding this data point into the research studies that look at the efficacy of our treatments. And we need to realize that even if our patient had a seemingly poor outcome, that there still may have been some good that came to multiple other people from the care that you provided to that one individual. Remember, what you do really does matter, even if sometimes it seems like it doesn't. If you want to catch up with us, you can reach out to us on Instagram at EMScast. Check out our website for show notes and additional materials at emspodcast.com. And please leave us a review on your favorite listening app. Until next time, be safe out there.